Welcome to the Understanding the New Hypertension Guidelines conference call. My name is Jenny, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star then 1 on your touch-tone phone. I will now turn the call over to Ashley Green. You may begin.
Thanks, Jenny, and good afternoon, everyone. Welcome to our webinar today. My name is Ashley Green. I'm a Quality Improvement Project Specialist with Lake Superior Quality Innovation Network here at Metastar in Madison, Wisconsin. We're one of the 3 partners, including Stratus Health in Minnesota and MPro in Michigan, who make up the Lake Superior Quality Innovation Network, and we're happy to welcome you to the webinar this afternoon with Linda. Just a couple of quick housekeeping items before I introduce her. During the course of the webinar today, we want to encourage you to use the chat box as questions arise. Linda and I will do our best to kind of monitor that, but we'll also save a few minutes towards the end of Linda's presentation to have a short Q&A session as well, so you can certainly save any questions you have for the phone line. Lastly, I wanted to let all of you know, if you're inspired by the material today or otherwise just have an interest in improving cardiac health care outcomes, Lake Superior has developed a new hypertension management toolkit, which has some great patient and clinic-facing resources that you may be interested in. You can find that on the Lake Superior website under the Cardiac Health Initiative, so be sure to check that out if you have any interest. And so with that, I'll go ahead and introduce our speaker today, Linda Murakami, who's a Senior Program Manager for Quality Improvement in the Department of Health Outcomes at the American Medical Association. In her role there, she provides leadership and technical expertise to primary care teams by conducting evidence-based quality improvement coaching. Prior to joining AMA, Linda has directed quality improvement programs in the ambulatory and home health settings. She was also the administrator for a home health agency in the Chicagoland area, where she led operational, quality, outcome, and compliance activities for the organization. Linda has a clinical background as a registered nurse with a focus on the medical and oncology patient population. And so with that, Linda, welcome, thank you, and take it away.
Thank you, Ashley. And thank you, everyone, for taking the time to join us today. So here's our objectives for today. Understand the revisions to the hypertension categories in the 2017 Hypertension Guidelines. Learn how the 2017 Hypertension Guidelines affect blood pressure measurement in and out of the office setting, and understand how to prevent clinical inertia and how to engage patients in controlling hypertension. So let's start about talking, about what's new in the hypertension control. At the end of 2017, the American College of Cardiology and the American Heart Association published a new report to help guide the diagnosis and treatment of hypertension. This updates the previous report that was written in 2003. The full report can be found on the targetbp.org website, as well as the American College of Cardiology website and the American Heart Association website. But know that the full report is about 400 pages long, so I'll review a few highlights. It'll save you some time. And I also want to point out that we realize some practices and health systems don't plan to follow the new guidelines, but some of the elements for improving blood pressure control incorporated in this webinar are useful regardless of your current definition of blood pressure control. So I want to talk a little about the MAPP framework that the AMA worked to develop beginning in 2013. MAPP refers to measure accurately, act rapidly, and partner with patients, families, and communities. It's an evidence-based framework. It's been shown to improve hypertension control rates, and it aligns with the recommendations within the 2017 ACC-AHA guidelines for hypertension. The diagram here shows how they all connect and work to improve hypertension control, and I'll be describing these aspects during today's webinar. And here also are a couple of articles that's been published about how the program works to make improvements to hypertension control. We've had the privilege of working with various practice sites across the country and found this program is very highly effective. In South Carolina, we worked with a residency practice that had a baseline blood pressure control rate of 61.2%, and after implementing the BP improvement program for 6 months, their blood pressure improvement control rate rose to 89.9%. We then worked with 16 family medicine practices, and their blood pressure control rates increased from 66.1% to 74.8% in just 6 months. Again, we'll be following the process for measuring accurately, acting rapidly, and partnering with patients to improve hypertension control as we discuss these new guidelines. So these are the categories that are now used in the new guideline. Normal blood pressure is less than 120/80 millimeters of mercury. And a new category of elevated blood pressure has been established for blood pressures between 120 and 129 millimeters of mercury over less than 80 millimeters of mercury. Stage 1 hypertension now starts at 130/80, and this category tops out at 139/89. Stage 2 hypertension is anything greater than or equal to 140/90 millimeters of mercury. Previously, stage 1 hypertension was categorized with blood pressure greater than or equal to 140/90. Now that this is considered stage 2 hypertension, the prevalent rate has increased for hypertension. But just because stage 1 hypertension starts with a blood pressure of 130/90, they're not saying everyone has to go on medication to treat it. New patients who are not on medications will start with lifestyle changes like diet and exercise. Many people can effectively bring their blood pressure down just by changing what they eat and moving around more. And know that improving blood pressure control in even 5% of the population across the nation will have the potential to save millions of lives. So the new guidelines stress taking the average of 2 blood pressures on 2 or more occasions. That means at a clinic visit, at least 2 blood pressures should be taken and averaged. The average of these 2 blood pressures is what you should document in your electronic health record. And a diagnosis should not occur until another set of blood pressures are taken on another occasion. The United States Preventive Service Task Force guidelines have made the recommendation for out-of-office blood pressure measurements since 2015. Now the 2017 ACC/AHA guidelines are reinforcing that recommendation for out-of-office blood pressures to confirm the diagnosis of hypertension. Out-of-office blood pressure measurements can be done in 2 ways. First is 24-hour ambulatory blood pressure measurement, which is also referred to as 24-hour ABPM. This is performed by having the patient wear a blood pressure cuff for 24 hours and also takes the blood pressure readings every 15 to 20 minutes while they go about their usual day. And the machine can be set to take blood pressures during sleep every 30 minutes so as not to disturb sleep if the patient is a light sleeper. The blood pressures taken during sleep can identify nighttime hypertension, which is an indicator for increased mortality. Self-measured blood pressure, also referred to as SMBP or home blood pressure monitoring, is a second way to measure out-of-office blood pressure. It takes the blood pressure at home or in their usual environment. Both of these methods remove the patient from the clinical setting, and because of that can help identify white coat hypertension, which happens when patients have an alerting response when members of the clinical team are present. And it also works to identify MAPP hypertension, which is when high blood pressure only occurs outside of the clinical setting. Literature strongly supports the use of SMBP for out-of-office readings, and it closely correlates to that of 24-hour ABPM. So here's just a table that kind of gives you a visual to differentiate the patterns for blood pressure. Blood pressure readings that are high in and out of the clinical setting indicates the patient may have sustained hypertension, which means they are not yet under control. You can see that for MAPP hypertension, the blood pressure is normal in the office, but high at home. And the opposite is true for white coat hypertension, where blood pressure readings are high in the office, but normal at home. And these are some of the actions you take to detect white coat and MAPP hypertension and to confirm a diagnosis for those who are not on any hypertension drug therapy right now. So you can see there's a 3-month trial of lifestyle changes in the first line of treatment, which I mentioned previously. So introducing blood pressure meds only begins if that fails to bring that blood pressure below 130/80. And for patients already on antihypertensive meds, you look at blood pressure measurements results along with any increased risk for cardiovascular disease or evidence of target organ damage to guide your treatment plan and diagnosis. This requires further screening and out-of-office blood pressure measurement, such as SMBP or the 24-hour ABPM. We'll move on now to measuring blood pressure accurately. So here's some quick highlights on accurate blood pressure measurement. I'll detail more steps shortly, but I cannot stress enough the need for accurate blood pressure measurement each and every time a blood pressure is taken. Providers rely on accurate blood pressures to properly diagnose and treat the patients. Blood pressure needs to be taken with a validated device, and also always use an upper arm cuff. Automated office blood pressure, also known as AOBP, is considered unattended because these devices will automatically take 3 or more blood pressures and can be done without the clinician in the room. This, along with out-of-office blood pressure measurements, is helpful when trying to eliminate that white coat effect. I know many people are still taking manual blood pressure measurements, so remember to palpate the radial pulse while pumping up the cuff and go 20 to 30 millimeters of mercury beyond that point. And this will ensure that you always hear that systolic blood pressure or that first carotid cough sound. And everyone, please deflate the cuff slowly at 2 millimeters of mercury per second. It'll really help make sure that you can hear those carotid cough sounds. So we want to make sure everyone uses the correct cuff size. Using the incorrect cuff size is the #1 error when taking blood pressures. You can falsely get high or falsely low blood pressures if the cuff is too tight or too loose. So the best way, to do is to use a tape measure to determine the circumference at the bicep area. And there's that graphic there showing you where to measure. And then here's just a small table showing you after measuring the arm circumference, you compare it to this table to ensure the proper cuff size, and check the sizing that is usually directly on the cuff you're going to use. And now we'll talk about 6 steps to measure blood pressure accurately. Again, these steps align with the recommendations of the 2017 hypertension guidelines. So you'll want to follow these steps to get the patient ready. They should be relaxed and preferably rested for 5 minutes. If you're unable to do this, take the blood pressure as your last vital sign. As your patients come into the office, start educating them to avoid caffeine, exercise, and tobacco for at least 30 minutes before their visit. Have the patient empty their bladder if it's full prior to measurement. And while we're all trying to ask all the necessary questions to the patients about their recent medical history, you'll need to do that before or after you take the blood pressure because no one should be talking during the measurement. Always make sure the cuff is on bare skin, so the patient may need to remove clothing. If you're rolling up their sleeve, make sure you can fit 1 to 2 fingers comfortably under the arm or under the shirt sleeve to confirm you did not create a tourniquet effect. Again, you can always use this as time to help educate your patient for future visits, asking them to wear short sleeves so you can properly take their blood pressure. During cold weather, just suggest that they wear a sweater or another shirt over that short sleeve shirt. And make sure measurements are taken sitting in a chair and not on an exam table. As I mentioned before, you want to use a validated office device and make sure it's calibrated. The AMA and the AHA are currently working on a validated device listing that should be up online in the next few months, but definitely by the end of the year. In the meantime, Hypertension Canada has a validated device listing that's useful. Be sure to support the patient's arm with the cuff at heart level. And again, remember that incorrect cuff size is the #1 blood pressure error, so use the right size cuff. And we've worked in practices with policies that state whether you should use the bell or the diaphragm to auscultate the carotid cuff sounds when you're doing manual blood pressures. So know that in the literature, either one can be used. And here's our great graphic that shows you how to properly position the patient for blood pressure measurement. It also tells you how the blood pressure will be affected if you don't follow the recommendations that I've been talking about. But talking, have a full bladder, not supporting the arm can all affect the blood pressure by 10 millimeters of mercury. And look what putting a cuff over the clothing can do. It can raise it by 5 to 50 millimeters of mercury. That's significant, and that's why you should never do it. So when new patients come to the office, you should be taking their blood pressure in both arms. So this is the first visit for your new patient. You'll use the arm with the higher blood pressure for all future readings, so you could, if you can, mark it in your EHR as the blood pressure arm. Also, if the difference between the two arms is greater than 10 millimeters of mercury, you should notify the provider, as there could be some other cardiovascular issue present. Take multiple readings at least 1 minute apart. The new guidelines recommend at least 2 readings be taken and average at each visit. Again, if you're doing AOBP, you would be averaging 3 or more. And you should always use some form of out-of-office blood pressure measurement to diagnose hypertension, as I mentioned, 24-hour ABPM or the SMBP method. Then you want to properly, document your readings, so it's kind of self-explanatory there, but make sure you do it right after you take the measurement so you don't forget it. And also note the time of any blood pressure meds that they may have taken before the visit. As I mentioned before, we should again average those 2 readings on 2 separate occasions to determine what the category the patient is in before diagnosing hypertension. And it's just good practice to make sure your patients are informed on what their blood pressure is. So make sure you give them their results on the visit summary sheet. And you can also tell them verbally right after you take it. So we suggest taking confirmatory blood pressure readings for out-of-range and elevated blood pressures. Depending on what guideline you use, it'll be either 130/80 or 140/90. As I mentioned before, there's AOBP, the automated office blood pressure. They can take the 2 to 3 readings and can be set up to be taken 1 minute apart and can be done with the clinician leaving the room when the readings are being done. It's a great way to identify white coat hypertension since the clinical team's not in the room during the measurement. And if you're doing single automated or manual blood pressure readings, just make sure to allow that 5-minute rest period. It'll make a difference in those measurements. And then take, your first reading and then your second and third, timing it 1 minute apart. And when you're doing the AOBP, so you don't miss any time in between patients, you can set a timer so you know when to go back after those 3 readings are automatically done. Usually 5 minutes is enough time for that to take place. All right, so we're going to move on to acting rapidly. So the guidelines are using the 10-year ASCVD risk calculation, the atherosclerotic cardiovascular disease risk calculator. You can find it on the American College of Cardiology website. Some EHRs already have it built in the system, so when you click it, it already takes that patient's age and cholesterol and everything that you need, and gives you that risk number right there automatically. And there's also several apps that you can use on your smartphones that'll help you with that. But when you look at this information on the slide, the moral of the story here is if there is a diagnosis of hypertension, the target for control is less than 130/80. And while we know that some patients cannot tolerate their blood pressure being this low, which happens more often in the elderly, any improvement in blood pressure will overall provide an improvement in health. So we must realize, though, that improving blood pressure measurements alone won't improve blood pressure control. Uncontrolled blood pressures are the result of 2 main factors. Clinicians may miss opportunities to treat patients who have uncontrolled blood pressure, or patients may not adhere to their treatment plan. I think we all know that can realistically happen and does often. So these factors collectively are known as clinical inertia or therapeutic inertia. And acting rapidly and partnering with patients will help you, lessen this issue. So I want to share this image, which
housekeeping items before I introduce her. During the course of the webinar today, we want to encourage you to use the chat box as questions arise. Linda and I will do our best to kind of monitor that, but we'll also save a few minutes towards the end of Linda's presentation to have a short Q&A session as well, so you can certainly save any questions you have for the phone line. Lastly, I wanted to let all of you know, if you're inspired by the material today or otherwise just have an interest in improving cardiac healthcare outcomes, Lake Superior has developed a new hypertension.
We make a great impact on the health of the nation. Okay, so most national experts in hypertension recommend using treatment protocols. Treatment protocols are like having a playbook for hypertension. It makes it very clear to everyone and on the team when patients need treatment, what the treatment should be, and how soon follow-up should occur. So here's an example of the management protocols provided in the 2017 ACC-AHA guidelines for hypertension. One study found delaying treatment intensification by as little as 6 weeks or follow-up by more than 10 weeks can increase the risk of heart attack, stroke, and death in patients with hypertension that have a systolic blood pressure greater than 150. If you recall, I mentioned that having a blood pressure 130/80 on a patient without a confirmed diagnosis of hypertension would start with diet and lifestyle interventions. It's represented here on the graphic. For patients with a less than 10% clinically calculated CVD risk, non-pharmacologic therapy is the first line of treatment with a follow-up in 3 to 6 months. This is an area that people seem to have a little more anxiety when they're talking about the updated guidelines. Now, you'll see with patients for the same blood pressure but a higher calculated ASCVD risk score, you'll need to add a blood pressure lowering medication. Plus, you're going to add diet and lifestyle to the treatment plan. These patients will require monthly follow-up until they're within goal of blood pressure management, which for the new guidelines are less than 130/80. So frequent follow-up is key. Treatment algorithms are meant to serve as guidance and can help everyone be on the same page, but are in no way meant to replace sound medical judgment. There are times when what is in the algorithm may not be the best method of treatment for the patient, and in those situations, treatment should definitely be customized to the individual patient needs. There are many algorithms out there available, so we just recommend that you pick one that works best for your practice and your population. Or you can, of course, create your own. So we've listed, a few here as a starting point should you need one. And if you review the 2017 hypertension guidelines, if that's your method that you're going to use as your control rate, they've got information in there that if you follow it, it's essentially developed a treatment protocol right there in the guideline. So prevention of clinical inertia requires follow-up for those out-of-range blood pressures. Outreach can be based on a list of patients who need a visit. You can contact the patients via phone, via letter, or through your patient portal. But when you're doing this, you want to identify processes for who will do the outreach. So what method you're going to use, who's going to see the patient for follow-up are all things that you need to determine. Some will return to the regular provider, but some practices have a process to follow up with another member of the clinical team. I know a lot of nurse practitioners that kind of get, placed with those patients, on follow-up. And some places do have kind of drop-in services where they have a blood pressure taken, and then if it's elevated, they're going to have that blood pressure addressed. So continuing to discuss the need for follow-up, if you follow the sample algorithm in the new guideline, once we get patients started on their medications, it's another time you'll want to frequently follow up. You're looking to see if new medication or dosage is affected or if any other changes need to be made. The guidelines recommend follow-up monthly, but we know practices that have patients return every 2 weeks for blood pressures that remain out of control. Again, it's based on the patient's condition. They may have comorbidities or target organ damage that may affect the need for a quicker return or follow-up. They may need to keep coming back until that blood pressure is controlled. And for only lifestyle management changes, you'll bring them in after 3 to 6 months because seeing the effects of these changes are going to be taking a little longer. Reiterating, losing patients to follow-up means no follow-up appointment, which was scheduled where the patient didn't show up for the appointment. A lot of practices have seen success when they engage the front desk and checkout staff in this, and it does work. Some sites use EHR messages or alerts in the patient's chart to notify the front desk staff that the patient needs an appointment before they leave the office. Other practices set up alerts in patients' charts so they don't so that if they don't call to schedule their appointment within a designated time frame or miss their appointment, they call the patient and help them schedule. Another thing to consider that a follow-up can occur in various forms. It can be the patient has a visit with a provider every time they come in, or they can see the nurse or an MA for that follow-up blood pressure check. And again, if the BP remains elevated, then we have to make sure they see their provider or a provider. So we'll move on to the partnering section now. Now let's talk about why we need to partner with our patients. The act of engaging patients in self-care can actually increase their adherence to care plans, which can result in improved blood pressure control. Again, a few ways we can do this are through the use of evidence-based communication, promotion of healthy lifestyle, and training and encouraging patients to self-measure their blood pressure. So here's a short list of some of the issues patients may be facing or experiencing that increase their cardiovascular risks. And if they made some changes, might show some improvement. So we really need to encourage patients to participate in their care in an effort to decrease the risk for mortality related to hypertension and any comorbidities that may be present. And, clearly I think these are obvious, risks and things that we can do to decrease risk factors, easily stop smoking, watch our diets, increase activity, and so on. So this slide and the next one are pulled directly from the new guidelines. It's got a great representation of how making modifications to lifestyle can affect your blood pressure. So let's go through some of this now. In the line for weight loss, we're talking kilograms. So remember that is equivalent to 2.2 pounds. Losing 1 kilogram or 2.2 pounds will equate to a 1 millimeter of mercury reduction. So if you lose 5 pounds, it's over 2 kilos, you'll lose 2.2 millimeters of mercury improvement. Using the DASH diet as a guide for people with normal blood pressure, you can reduce your systolic blood pressure by 3 millimeters of mercury. But look at the difference for hypertensive patient. It goes up to 11 millimeters of mercury. So that's quite a significant drop. And dietary intake of sodium should be at 15 milligrams per day. But ideally we should aim for 1,000 milligrams of sodium. That's not very much sodium, so we really need to teach our patients how to read food labels. And the new change that has been added is increasing the amount of dietary potassium we consume daily. It's preferred that through diet, and we aim for 3,500 to 5,000 milligrams per day. Increasing potassium seems to blunt the effects of sodium, but please note you are to use caution or eliminate this suggestion in patients with chronic kidney disease or any other disease process or medication that is affected by increased potassium. And when we talk about physical activity, make sure your patients know that they do not need to be a marathon runner to benefit from increasing activity. You can see that 30 minutes of activity, 5 days per week, can help reduce your systolic blood pressure. And reducing alcohol consumption for those who currently drink alcohol is suggested, and patients need to limit it to 2 drinks per day for men and 1 drink per day for women. Here's some examples of information that may assist your patient with adherence to therapy. Teaching them about high blood pressure is one step in helping them understand how dietary measures may lower and improve their blood pressure. These tools are available at targetbp.org website along with several others. And at the bottom of the slide is the DASH Diet website, which is dashdiet.org. So So we're all likely communicating with our patients every day in our own styles, but we want to share a few examples of evidence-based communication strategies. We can gain information and provide guidance that may make the patient feel more comfortable and less threatened or defensive. It's suggested to use open-ended questions, not just those that elicit a yes or no response. If you know that the patient missed a previous appointment, bluntly asking why did you miss your appointment may make them feel like they're being judged, unless you could, you should instead say something like, I noticed you missed your visit 2 months ago. What can we do to help you with your follow-up care? You might actually find out they're having issues with transportation, or maybe they don't have money for the bus ride. Or let's say your patient's been missing doses of their medications. You can say, have you considered using a pill box? If the patient's issues that they have difficulty getting to the pharmacy when their refill is ready, pill box is not going to help them. So you might want to say something along the lines of, what do you think would work for you, or what has worked for you in the past? This encourages the patient to think of solutions that may help address the specific barriers they're facing. The way questions are posed and the way they're delivered can go a long way in allowing you to learn more about your patients and work with them to make plans that are specific to their needs and that they feel confident when they adhere to. So I'm pretty sure everyone has patients who have trouble adhering to the medication plan for various reasons. So we want to educate them on how to use their medication, why it's important, and what effects we expect to see as a result of them taking their medication. It may also be helpful to inform patients to call the office if they experience any side effects instead of just them stopping the medication and us not finding out about it until the next visit. Whenever possible, we should try to use medications that only have to be taken daily to help with the cost, and order generics when you can. Using single pill combination drugs is found to be extremely helpful, as seen with studies done by Kaiser Permanente. And while it's easier to be compliant for the patient, I just want to make sure you check with the patient's insurance plan that it will be cheaper if cost is already an issue for the patient. Some plans don't cover these drugs as well as they do for ordering the drugs separately. Seems silly, but I've worked with practices where they've seen this as an issue. And whenever you can, provide patients with 90-day prescriptions to decrease the need to get refills. Also, and if you can help the patient coordinate the timing of all their refills so they don't make extra trips to the pharmacy. So making sure that if they're on multiple meds that they need to be refilled at the same time so they don't make 3 trips to the pharmacy instead of just 1. As a care team, we should try to proactively identify any financial barriers that may prevent the patient from being able to afford the medications and find ways to address that. Again, we're encouraging generics here, but also looking for pharmacies with programs that, for example, may provide low-cost antihypertensives. There are some out there who will do it for $5 or $6 per month. Blister packs can be helpful if the pharmacy offers that, but pill boxes are useful as well. And including the patient when making the treatment plan can go a long way with med adherence, as well as compliance with the rest of their care plan. So self-measured blood pressure, or SMBP as we mentioned, is recommended throughout the new 2017 guidelines. So when a patient takes their own blood pressure outside of the clinical setting, most people do it at home. It's used to confirm a diagnosis and identify white coat hypertension, but it also helps providers know if the changes made in blood pressure medications is working. Additionally, even patients using lifestyle modifications can use SMBP to gauge the progress. And using SMBP can help with engaging patients in the treatment of their high blood pressure. Every patient instructed to do SMBP must be provided with guidance on what to do if they have readings that are out of range. So whether it's call the physician office during office hours or go to an urgent care or ER out of office hours, if a patient has blood pressure that is too high or too low, or if they have any symptoms, they need to know what to do. So there's strong evidence that shows when SMBP is done along with providing additional clinical support, it enhances the lowering of the patient's blood pressure and is sustained for longer periods of time. Again, there's information on targetbp.org on self-measured blood pressure. Just look for the links that mention patient-measured blood pressure. SMBP also takes us back to the medication adherence discussion we had a few slides ago. One study showed us that there's 95% compliance with SMPP as opposed to 72% compliance without it. It's a great way to, improve that patient engagement in their care. And I mentioned the clinical support with SMPP, so here's what we meant by that. You need to make sure that there's regular means of communication for the patient back to the practice to talk about their blood pressure readings, especially when they're taking readings to rule out white coat hypertension or when you're adding new meds or titrating the current meds that they're on. Having readings in a timely manner means you can address these issues or any issues without delay. So here's the effects of using SMPP and providing additional clinical support. While you see there's a good drop in blood pressure without additional support at 6 months, it's not sustained at the 12-month time frame as it is when you're providing additional clinical support. So you can see it goes from 2.4 millimeters lowering only down to 0.8 millimeters of mercury at 12 months, but sustained at 4.4 millimeters of mercury at 12 months with that additional clinical support. So you need to instruct your patients how to buy, or that they need to buy a validated automated upper arm device, preferably one with memory and averaging. It's the same as we mentioned for devices in the clinical setting. You should always buy validated devices, even in the clinical setting. The technology on home devices now also includes Bluetooth capability that transfers the reading from your blood pressure monitor to your smartphones. So keep in mind, these are probably going to cost more. The more bells and whistles, the higher the cost of the device. But, it is a benefit if the patient can afford it. Also, do not have the patient use a wrist cuff unless it's impossible to do brachial readings with an upper arm cuff. And never use finger devices because they're just not accurate. And when a patient does purchase their own device, make sure they bring it into the office and you should test it for accuracy. You want to instruct the patients for doing SMPP to take readings twice a day, in the morning and in the evening. They should take 2 readings 1 minute apart, and always instruct them to take readings for 7 days, but if it's a problem, 3 days is at a minimum is okay. Having them take blood pressure readings the week before an office visit is useful to gauge current blood pressure control, especially for those with white coat hypertension, knowing the office reading is probably going to be elevated. And once controlled, the frequency of the monitoring at home can be diminished and decreased. So here's some examples on how the patient can communicate blood pressure readings back to the office. They can call the office, send a fax, so they can use their patient's portal. Bluetooth devices that can transmit their readings to an app on their smartphones are present, so they'll likely have that phone with them when they come for your office visit, so you can also check the results that way. Some also have the patient return to the office if the home device has memory, so they can bring it with, and you can go back and scroll through the readings personally. And to use home readings for treatment purposes, you're going to average all the readings into a single systolic and a single diastolic reading, and that would be your treatment blood pressure. So there's things that patients must know to properly perform self-measurement, and this document can help staff ensure they relay all important information to the patient during the training session. It's just sort of following steps and making sure that they don't miss anything when they're trying to do it. So we want to making sure that they're positioning themselves at home properly as we have instructed on that red graphic in all settings for the patients to do. There's also available a 7-day recording log. Helps your patient provide a place to document all their readings when they take it over a course of a week. As you can see, we recommend having the patient take the 4 readings a day, 2 in the morning and 2 in the evening. There's a place for that. There's also a place for patients to document their pulse with each reading. And lastly, at the bottom, you can see there are places for you in the clinical setting to provide customized information for your patients. So in addition to the paper copy, there's an Excel version of this in case your patients prefer that format. Just like the graphic we showed earlier, the red one, this graphic is a great tool for the patients. It helps them know what to do before, during, and after they take a home blood pressure reading. proper positioning really makes a difference, as we instructed before. We want to have proper positioning for blood pressure measurement at home, just like we do in that clinical setting. Not following the guide for positioning can increase blood pressure readings by several millimeters of mercury. Always make sure that cuff is placed on bare upper arm. And if you recall, putting that cuff over clothing can increase the blood pressure reading by up to 50 millimeters of mercury. There's a video, here's a link to it that can help you train your patients on how to do self-measurement. It's on targetbp.org, and it's actually available in English and in Spanish, and lasts for 3 minutes and 45 seconds. The American Medical Association and the American Heart Association have partnered together to develop a program called Target BP. So here we provide information and guidance that can help clinical teams improve blood pressure control. There's an improvement program and a recognition program with 2 levels of recognition. And there's a participation status for sites providing data and committing to improving blood pressure control. And gold status for those with blood pressure control rates of 70% or more. Again, there's information to improve blood pressure control through quality improvement mechanisms. There's also many tools and resources to download that can guide an improvement program or an improvement plan. And if anybody wants to talk about getting assistance with blood pressure improvement through Target BP, reach out to your local American Heart Association affiliate staff. Again, here's the website where that information can be found. And now let's open it up for questions.
And just a reminder, folks, that you can use that chat box if you prefer. And Jenny, could you remind everyone how to ask a question on the phone, please?
Yes, thank you. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. And we have no phone questions at this time.
Okay. Then with that, I will thank everyone for joining us today. And here's my contact information on this last slide. Should you need something at a later date, maybe come up with a question later when you're trying to do something, feel free to give me an email or give me a call. I'll pass it back to you, Ashley.
All right, yeah. Linda, thank you so much for your time today. We really appreciate your insights and discussion of these important new guidelines. And thank you, of course, to the AMA for being such a great partner to Lake Superior and other healthcare organizations in this all-important effort. We're looking forward to some really good health outcomes when it comes to cardiac health. So again, if you do have any questions, please reach out to Linda. She's always happy to answer those. She's been a wonderful partner here in Wisconsin. You can also reach me, agreen@metastar.com, if you have related questions. Always happy to field those. And then finally, again, if you're looking for additional resources or maybe just want a little more inspiration in your own organization's efforts to improve these outcomes, be sure to stop by the Lake Superior Quality Innovation Network website and check out that hypertension management toolkit. There's some good resources in there, including some from the AMA. So with that, we will thank everyone for the time. If you could take the quick evaluation and let us know how we did today, we'd appreciate that. And with that, I'll wish everyone a good afternoon, and thanks for coming.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.